Hello, I'm Felipe Medeiros. I'm a professor at Duke University, and I'll be talking to you today about new drug delivery approaches in glaucoma, which is a very important topic, given that one of the biggest challenges that we have in glaucoma is patient adherence to topical treatment with eye drops, as we shall see. These are my financial disclosures, and I have been a consultant to a number of companies. They're involved in the area of developing new sustained drug delivery approaches in glaucoma. So why do we need new drug delivery approaches in glaucoma? As I mentioned, the poor adherence to topical treatment with eye drops is a major problem that we have in glaucoma. In this large study, Dr. Newman Casey and colleagues, they showed in a sample of over 1,200 patients with newly diagnosed open-angle glaucoma that only about 15% showed what they called persistently good adherence to topical treatment over 4 years of follow-up. So it's a very, very low number. And so here's what they did. They looked at a metric called medication possession ratio. Okay, and this measure the proportion of time that the patients were supposed to be using the medication that they had the refills. And the patients were classified according to the patterns on this medication possession ratio over time. So if you look at these at this figure here, you're going to see that the patients were classified in these 5 groups here. So there were those patients who were really never adherent to medication. So they never really had a medication possession ratio that was above 10-20%. So they're never really using the medications. There are those that are persistently very poor that had ratios around 20%. So they essentially were using the medications only about 20% of the time, probably when they were about to come to the doctor or something like that. But there were those who started well, but then quickly declined over time. And there were those who had a moderately good adherence to medications, and there were those who were persistently good, who had medication possession ratios of 70-80% over time. And as you can see here, we see on the bottom that the proportion of patients on these 5 groups, and as you can see, the proportion of patients who were in groups 4, if we consider the persistently good, it's only about 15%. If we also consider the moderate ones, persistently moderate, then we have somewhere around 50% or so. So essentially, even if we consider the persistently moderate as adherent to treatment over time, that number is just around 50%. So why patients are so poorly adherent to eye drops? Well, there can be many reasons. They forget to use them. In the case of glaucoma, there's no immediate symptomatic benefit from using the drops. So it's not that they use the drops and they necessarily notice an improvement in their condition. And drops, of course, can have side effects. The eyes can get red, their dry eyes can get worse. There may also be coexisting conditions impairing self-administration. It's important to remember that glaucoma is a condition that is associated with aging. And a lot of patients with glaucoma, they may also have coexisting conditions that may make it difficult for them to administer eye drops, for example, rheumatoid arthritis and some other conditions. They may need family members to administer the drops as well. So how can the problem of lack of adherence be addressed? And there are a number of publications, a number of studies that have looked into that, and things like education and reminders. And these studies, they do show some effect of programs trying to improve the education and importance of adherence to the medical treatment. But they have shown that you only see a modest effect of around 19%. And it's likely not sustainable over time. And in fact, these studies, in general, they involve highly selected patient populations because the patients know they're being monitored. So it's likely that the adherence is better than in the real world. So if you actually look at the effect of these interventions in the real world, it's likely that's going to be much worse. So importantly, the poor adherence leads to worse outcomes. And this was shown again by Paula Newman-Case's group, where they used data from the collaborative initial glaucoma treatment study to show that they had the group of patients who were in the CIGITs randomized to medication and followed over time. And they showed that patients who missed 2/3 of the doses over time had almost 4 times greater loss of visual field compared to those who did not miss any doses. And that, of course, makes sense. So they assessed medication adherence in this study by asking the patients by telephone, so whether they had missed any dose of their medication the day before. And over time, a number greater than 50% of patients, they confessed that they actually missed drops up to at least a third of the visit. So, and you can see in this plot here. And an important thing here is that these were patients that were enrolled in a clinical trial. So these were patients who were part of the trial, so likely patients who had a higher chance of being more adherent to treatment. So again, the numbers are likely higher in the real world. So there were some differences between those patients who missed a lot of doses versus those who did not. And in particular, for example, race was an important factor with a much larger proportion of Black patients that missed the dose. So here you see a relationship between the loss of visual field over time and the proportion of doses that were missed. And you can see these are estimated slopes, and you can see that there were faster slopes in the group that missed a larger number of doses. So they progressed faster over time. So then it becomes very clear that there is a problem of poor adherence, that current methods of education and reminders don't really have the desired effect in improving this, and that the poor adherence is a very significant problem because it leads to worse outcomes and worse loss of vision in patients with glaucoma. So then there's a clear need for better methods to deliver drugs in glaucoma patients. So we recently had some advance in this area with the development of the Bimatoprost slow release implant, or the Durysta as it's commercially available now. And the Durysta is based on a similar platform to the Ozurdex. So it's a little implant that is inserted into the anterior chamber with the applicator. You can see here, it looks like a pen. It has a little needle, and you apply with a 28 gauge needle that you then enter the anterior chamber, release the implant. The implant is very tiny. You can see here compared to a dime that is about the same size as the eye of the dime. And the implant will then dissolve over time, and will be transformed to water and carbon dioxide. So it doesn't need to be removed. So I'm going to show a little video here of the process of the implant being inserted into the anterior chamber. So you see this being done at the slit lamp. Is usually a very straightforward procedure. Then you press and you release the implant, and the implant will generally settle at 6 o'clock or around that. You can see here on gonioscopy that the implant settled there. So early studies, early animal studies that were performed in canine models, they showed, comparing the implant with the topical administration, they showed that actually you would get a higher concentration of the drug, bimatoprost, in the aqueous humor and iris ciliary body. You can see here the black bars. You would get a higher concentration of the drug with the implant compared to the topical administration. This is key because you are addressing the target tissues. But when you look at the other tissues like the conjunctiva, the eyelid margin, then where you actually get side effects from these drugs, then you can see that the concentration was much lower with the implant compared to the topical administration, which of course makes sense given the way the implant goes into the anterior chamber. There have been phase 3 studies looking at the results of the bimatoprost implant in patients with open-angle glaucoma and ocular hypertension. This is a study that we published back in 2020, the Artemis study. And what the Artemis study was a randomized study that included 2 parallel group, was 2 non-inferiority studies versus timolol applied 2 times a day. And the way the study was set up was that patients received an implant every 4 months. So they received 3 implants, and the implants were placed every 4 months. Patients who were randomized for the implant versus a timolol. Okay, so every 4 months they received the implant. And this was based, the design for this study, why 4 months? This was based on the early studies, as I mentioned, the early studies in animal models where the presence of the drug was not detectable after 4 months. So then it made sense to do this setup of every 4 months. But as we're going to see later, it turns out that the effect seems to be sustained for longer periods in the majority of patients. So probably we don't need really applications every 4 months for the majority of patients. So these are the baseline characteristics of patients included in this study. So the bimatoprost and the timolol groups, and the Artemis study initially included the 15 micrograms and the 10 micrograms implants, but the 10 micrograms showed a better safety profile with an efficacy, so it was chosen to be the one to be commercially available. So these were the diagnosis of patients. You can see a large proportion of patients had primary open-angle glaucoma. Some patients had ocular hypertension or other types of open-angle glaucoma, pseudoexfoliation, and pigmentary glaucoma. But they were comparable between the groups, and the pressure at the beginning of the study was around 24.5, 24.6 millimeters of mercury. So the study met the primary endpoint on non-inferiority compared to the timolol in pressure lowering through week 12. Okay, so the pressure reduction was about 30%. You can see here dropped from 24.5 to around 16, 17 millimeters of mercury. So a drop of around 30%, which is comparable to what we see with a topical application of a prostaglandin analog. So during this primary efficacy period, the pressure lowering was graded with the implant compared to timolol at all 6 time points. So you can see this here, where you have the blue bars versus the gray bars. So the blue bars correspond to the implant and the gray bars to the timolol. And these are percent reductions in the IOP over week 2, week 6, and week 12. So if we look here at week 12, we can see that over 70% of patients had at least a 20% reduction in pressure. And again, in general, the patients with the bimatoprost implant had a greater reduction in pressure compared to those with timolol. A very interesting result that was observed, and I mentioned this before, was the fact that after the last implant administration, then the patients were followed over time, okay, so up to 2 years. And what we noticed was that 80% of patients remained controlled without a need for rescue medication at 1 year after the 3rd administration of the implant. So let me repeat this. They had 3 applications of the implant, of the bimatoprost SR. After the 3rd application, the patients remained for 1 year without the need for any additional medication. So 80% of the patients remained controlled. So showing some long-term duration of that. In a more recent study that we presented, where we looked at 2 years of additional follow-up, an extended follow-up period, we showed that some patients actually remained controlled remained untreated without a need for rescue medication for even more than 1 year, for greater than 2 years, or even some of them for even like 3 years after the 3rd administration. Interestingly, the patients who remained controlled over this long extended period of time, they had similar characteristics compared to all patients in the study. So similar baseline pressure and pressure 2 years of the last implant. So it was 23.5 at baseline and 17 2 years after the last implant. These were the patients, again, who remained unrescued for greater than 2 years after their last implant. So why do we get this extended duration of intraocular pressure control? This is interesting. And the proposed mechanism of action for this is that the implant would lead to a higher expression of matrix metalloproteinases with reduction in the extracellular matrix, greater tissue remodeling, and longer duration of IOP reduction. So the idea is you would get a greater concentration of the drug in the target tissues, and this would lead to more prolonged, sustained effects in terms of pressure reduction. So you can see in these images here, which is a proposed mechanism of action on the extracellular matrix. So interestingly is that a lot of the patients before they were during the screening period, they could be on 0, 1, or greater than 2 or greater than 2 medications at screening, and then they had the washout and were included in the study. It's interesting to note that there was no really difference in terms of the number of medications that the patients were using during that screening period and the probability of not requiring additional treatment 1 year after the 3rd administration. To see, it's about 70–80%, as we mentioned, regardless of the number of medications they were using before. Some interesting data that we have looked at is some visual field data on these patients. Of course, the ultimate goal is to prevent visual field loss in these patients. So the idea is that the sustained release implant perhaps will have a greater, will lead to better control of intraocular pressure over time, a more sustained and flat pressure control over time. And this may lead to better prevention of visual field loss over time. So what we observed in some preliminary data, visual field data that we observed, is that there was some difference in patients who were randomized to the implant, the bimatoprost slow release versus timolol. So there was greater preservation of visual field loss over time in patients who had the implant. Although this is preliminary data, and we still need to provide the analysis with more complete data set. So in terms of the adverse events, in terms of side effects of treatment, most of the side effects that one observes with this treatment is related to the procedures for sterilization. They're used at the time of the administration. Okay, so and then there may be some transitory conjunctival hyperemia or foreign body sensation, and that's what you see here in a good percentage of patients. But this is, again, it's related to more of the implant administration. So a concern is the potential for corneal endothelial cell density loss. Okay, so you see here the profiles of the eyes that had the implant over time, and in the trial, in the phase 3 trials, and with these 3 administrations every 4 months, the incidence of having greater than 20% corneal endothelial cell loss was around 10% with the 10 microgram implant. There was no difference in central corneal thickness or visual acuity in the group. So you can see here, even the patients with corneal adverse events, there was not much difference here in terms of corneal thickness, but you can see for all patients at baseline and at 20 months, there was no difference in corneal thickness. And also in baseline and 20 months for patients with corneal adverse effects, we don't also see a difference between baseline and 20 months. But again, there was an incidence of about 10% of the eyes of greater than 20% corneal endothelial cell loss with the implant. This was with the dosage that was performed every 4 months. However, what we have seen from the data that I showed is that the implant seems to have a longer duration than 4 months. As I mentioned, like 80% of patients remained drug-free for 1 year, for at least 1 year after the 3rd administration. So very likely you don't need to put the implant every 4 months. And the corneal endothelial cell loss, the risk for corneal endothelial cell loss is mostly seen in patients who have stacked implants. So when you administer the implants stay stacked and they may touch the corneal endothelium. Currently, the bimatoprost is approved for 1 administration with the Durista. So just giving a brief summary of what we have discussed, the phase 3 studies showed that the implant had no inferiority compared to the timolol and had a pressure lowering that was about the same as daily topical prostaglandins. A large proportion of eyes had pressure controlled for 1 year after the 3rd implant. There are some promising data in terms of visual field progression showing perhaps a slower visual field change in patients who receive these implants, but we need more evaluation to clarify the long-term effect in terms of these desirable endpoints for visual preservation in patients with glaucoma. So the Durysta has been approved by the FDA, but for a single application, as I mentioned, but there are ongoing clinical trials. They are evaluating alternative dosing schemes to support label expansion for the bimatoprost SCR. So again, very likely we don't need implants every 4 months. Implants perhaps could be done every 6 months or 1 year, depending on patient response. A lot of patients seem to be long-term responders. And some work that has been done has shown that in patients with single application, you do not really see the corneal endothelial cell loss, significant corneal endothelial cell loss, as we showed with these short repeated applications. So what are some other potential solutions for drug delivery? An interesting approach was published some time ago, and is this topical bimatoprost ocular insert, which is this ring that is inserted under the eyelid, as you can see here. The ring has a silicon bimatoprost matrix and a support structure here, and it's inserted under the eyelid. You can see it here. And then it dissolves over time. In this study published by Jamie Brandt, they compared it to timolol, but unfortunately, the pressure-lowering effect was not as sustained as we saw with the intracameral implant. Actually, you can see the blue circles here correspond to the insert, and the yellow triangles to the timolol, and you can see that over time, it does seem to lose the effect, and then you can start seeing differences compared to the timolol by around 6 months or so. It's interesting that actually, even though you put that ring under the eyelid, the patients rarely really complain of any ocular discomfort. Side effects were mostly conjunctival hyperemia that occurred in some patients, generally mild, but really very, very few patients with any severe, moderate or severe side effects. There's some other interesting approaches. One is the idea of an intracanalicular insert. Okay, Ocular Therapeutics, they had the ODX-TP, was this little intracanalicular insert that would then release the medication, release travoprost over time. However, unfortunately, in the clinical trial, they had a phase 3 randomized, double-blind, placebo-controlled trial with over 50 sites and over 550 patients, and they were not able to achieve the desired endpoints, which was a reduction in intraocular pressure compared to placebo. So it failed to achieve that reduction in all time points. So you can see that although it did achieve in most time points, but not in all of them. So it failed to achieve the primary goal and point of significant intraocular reduction in all time points. This is an interesting approach because it would be easy to use and very little invasive. Another interesting approach is the iDose from Glaukos, which they have now completed a number of clinical trials. This was published by Jay Katz at ARVO, presented at ARVO last year. And the iDose needs to be implanted surgically. So you will then take the patient to the operating room and you will implant this. It's similar to the iStent from Glaukos, but you implant this and there's a drug reservoir there that will slowly release the drug over time. And they conducted this randomized clinical trial with the iDose, and they showed significant pressure lowering of around 8 millimeters of mercury, which was comparable to the timolol in this study. Timolol also had a high reduction in pressure in this study here of 8. But interestingly, the number of patients who remained controlled on eye dose over time at 36 months was significantly higher than with timolol. So about 70% of patients remained controlled on the eye dose at 36 months, compared to only 46% with timolol. So this is an interesting, promising approach, but it does require taking the patient to the operating room. So you would need to then, perhaps every couple of years, every 3 years, you would need to replace with a new one. I personally find that such approach would be promising, especially if we can actually combine perhaps multiple drugs at the same time, so that patients can perhaps have the greatest benefit of such intervention over time. But it's a very interesting approach, also currently under investigation, and with some recent powerful results in clinical trials. So in conclusion, there are several promising avenues for sustained release medications in glaucoma. This is an important development in glaucoma, given the great challenge of lack of adherence to topical medications that we discussed. So far, intracameral implants have shown the best results. The current commercially available intracameral implant is the Durysta, and it does seem to show an efficacy comparable to topical prostaglandins, but with the advantage of long-term sustained effect, which could then again help solve the issue of lack adherence to topical medications, potentially decrease side effects, and lead to long-term better pressure control and improved clinical outcomes. Single application of Durysta, it's currently approved for only single application. This may have some limited clinical applicability. However, there are ongoing clinical trials that will hopefully support label expansion for multiple applications in the future. Thank you very much.
Welcome to the second half of this lecture on glaucoma, which will cover emerging 3D visualization technologies. I'm Robert Chang, Associate Professor of Ophthalmology at Stanford University, and today you will hear about the utility of 3D visualization in eye surgery. These are my financial disclosures. I am a consultant for Alcon and also receive grant funding from Alcon. Some of the slides have been adapted from Alcon material. However, no endorsement of any manufacturer is intended, and the included video is necessary to show the 3D visualization technique. In this lecture, you will hear about the conventional microscopes for ophthalmic surgery. I will cover the genesis of 3D visualization technology, and the ergonomic advantages of a 3D heads-up display will be reviewed. Examples of shared surgeon view and how this can help in the process of learning new surgeries in 3D, especially in glaucoma, will be discussed. And finally, I will be talking about heads-up display enhancements, such as the overlays to provide more information to the surgeon in real time. These enhancements keep improving as the technology evolves. So conventional microscopy in the operating room has been around in ophthalmology for decades. In fact, ophthalmology was the first medical field to use microscopes in surgery. Over the past 40 years, there are a few advancements focused around improving the light source, on reducing the scope size. Bright illumination could cause macular burns, so rheostat-controlled and less intense filaments were utilized to reduce ocular injury and yet still provide a bright red reflex. Because as we all know, this is quite critical for cataract surgery and viewing the posterior capsule. Each of these scopes shown here has special coaxial illumination technology to highlight more details of the ocular anatomy. And conventional scopes also became more portable over time as surgeons moved between eyes and between rooms. The scopes evolved from these bulky ceiling-mounted devices to smaller and lighter ones mounted on a movable base with extended arms for freedom of movement, including even now wireless technology and foot pedal control. So the surgery techniques evolved and surgeons were able to perform more surgery in less time. But the demand for eye surgery has not abated given our aging population. And still, we need the best technology available to do more surgery. Actually, the first surgical loupes used in ophthalmology dates back to 1876. And early binocular scopes for surgery arrived in the 1940s. Of course, this provides stereo view, which is quite important for depth perception. And then in the 1970s and 80s, there were optical and zoom enhancements that came along to make better visualization of the eye, as it is a small structure needing higher magnification in order to operate safely. But it's actually in 2016 when the 3D visualization era began with the launch of True Vision heads-up display. This was the original technology. At that time, 3D TVs were also touted, if you can all remember that. So there was a natural application to apply that technology to all surgery, not just ophthalmology. I had tried the early generation True Vision 3D TV setup and even saw it used in neurosurgery. But I do recall that there was some intermittent lag issues from the video feed to actually what you saw on screen. And this was a video processing problem that eventually got solved and was continually improved until now the camera system has no lag at all and works perfectly. Everything that you see on the screen happens in real time. So here we can see the progress of this earliest 3D visualization system. The Ingenuity, which was launched in 2016 from the True Vision, improved upon their TV screens with OLED technology by 2017. And then by 2018, there was integration of all our other ophthalmic surgical equipment. You know, we have the constellations for retina, the phaco machines, and all those machines' data were then overlaid onto the same screen on the Ingenuity. And in this way, the surgeon would not have to ask for settings or even have to look away from the surgical field. Everything started to feel a little bit more seamless and integrated. Also, new software updates could be added without it actually requiring any hardware update. And this gives ability to add more enhancement and augmented functionality, kind of like the way self-driving cars keep receiving their updates. One of the unique features of 3D visualization is that everyone in the operating room can have the same view as the surgeon's view. Normally, just the person sitting at the side scope gets the same beam splitter view as the surgeon view. But now, with everyone wearing 3D glasses looking at the same display, this is great for the surgical team who are following along, like your scrub techs and circulators. If they work with you for a long time, they can know exactly what step you're at and be ready with something that you may need. And in a teaching institution, this kind of setup is ideal for visiting trainees. It's a much improved view than just watching on a 2D monitor. You know, 3D has that immersive feel, and knowing depth during the eye surgery is so critical. So this picture is an example setup with the Artivo, which has similar functionality as the Ingenuity. But I think one important point to note is that the 3D stereo is actually best when you sit right behind the middle of the monitor rather than off to any side, as that can cause a small skew to the view. So this area of 3D visualization is also taking off in the virtual world, like the metaverse, as the hardware costs are really coming down and more people are trying it out. You know, surgical educational sections are now being mixed in 3D virtual worlds, and the future of mixed reality, which kind of means switching back and forth between the virtual world and real world, is starting to gain traction from the early adopters.
This hemorrhage that you can see here, high-speed cutter, we're using a 20,000 cut dual bore cutter. Here's the perforation site. I know the thought is, oh no, this is a disaster. They're going to have a retinal detachment. Not always, not always. So once we get all the vitreous off of that area, we're going to open up our avenue to remove the IOL. Good anterior capsule here. And the cataract surgeon actually said, hey, I want to put the secondary lens in, so leave them AFake. We do a soft tip lift.
So hopefully you heard some of that audio there. As you can see from the video, you know, people can interact in this virtual world kind of like a 3D Zoom. But I think the biggest barriers, you know, to adopting this technology, the virtual reality, has been sort of the headset dizziness that can happen after you wear it for a long time. And originally how costly and heavy those headsets were. with the prior generations in particular, and sometimes some eye fatigue that happened with latency issues. But the technology is rapidly improving. And I believe that once haptic feedback, which is including touch sensation, is included, that disconnect between seeing and hearing versus also feeling your joints that you're transported there will be less of an issue, because it's really the full sensory immersion, including touch, that's necessary for true virtual integration and less of that disconnect. So actually, there is one startup which is already harnessing the power of mixed reality in the ophthalmology operating room, and this is the Bionics device. You're able to see the eye like you normally would with this headset on because you get the real world input as well, but you have your data like in these screens on the right, lower right, OCT imaging, retinal display, or the biometry information from a cataract procedure. It can act as an overlay on top of what you're seeing in the real world. Now you could just imagine, what if one day, you are tracking on the fovea with a 3D overlay as you're peeling an epiretinal membrane. I think that's the power of thinking about where this kind of technology can go in terms of the digital video and tracking in real time. So in glaucoma, there can be landmark markings displayed on the video, such as maybe where the eye muscles are located when implanting a tube shunt. It's kind of like having guardrails, in your backup camera in your car, and you're trying to parallel park a car, and it kind of shows you some guidance as an overlay. So during this past decade, glaucoma angle-based surgery has become very popular as an intermediary step, treating mild to moderate glaucoma before proceeding to high-risk filtering surgery. These stents or otomy minimally invasive procedures were often added to cataract surgery. So now we have 3D visualization, no need to look in the oculars. Does that really matter? I think for high volume surgeons who are operating all the time, looking at the slit lamps every day, optimizing ergonomics is a big part of their career longevity. How's your posture? Many ophthalmologists suffer from neck and back problems near the end of their career if they're always hunched forward, looking into those oculars. It's much easier and less stress to lean back using a 3D glasses heads-up display. So here's an example demonstrating optimal angle for the neck and shoulders with heads up, heels down. In the first photo on the left, you can see that the surgeon's leaning forward in order to peer into the oculars. It's a little bit subtle, but that repeated strain on the neck over time can be a repetitive injury, such as you're seeing 50 plus patients a day at a slit lamp, often hunched forward, and then operating at a microscope all day. So you should be more about sitting back a little, even if you are using conventional microscopy. So now imagine with 3D heads-up display, this would be less of an issue. A study from Clinical Ophthalmology was published surveying 25 surgeons, comparing the difference between 3D heads-up display versus conventional microscopy. And in all areas, surgeons felt improvements. As you can see here on the graph, the gray bars, much better for reduced severity of pain, reduced frequency of pain, improved posture, etc. Overall, 82% of surgeons reported feeling less pain and discomfort during operations since using the heads-up display technology. So what makes this Ingenuity screen unique? Well, it's not just your typical conventional TV you can buy in the store. This is a special 3D 4K OLED screen which has 60 frames per second video processing simultaneously per eye. It is synced with an ultra high-speed graphics processor to make sure that there's no lag in what you see on the screen. And the camera itself has a very high dynamic range, which means that it can see at lower light and higher light settings than the normal eye, which is an enhancement over traditional optics. It also has a really large depth of focus, so that means able to stay in focus even under high magnification. And normally in conventional microscopy, when you zoom in, you have to adjust the focus. So it's a big help when once you've set your view, your field of view, you don't constantly have to change the focus throughout the case. It just, everything stays in focus. So if I had to summarize the 3 key highlights of 3D visualization technology and its advantage, it has to be this expanded depth of field compared to current microscopy with the current scopes, up to 5 times expanded field, and then up to 48% increased magnification with 42% increased depth of resolution, so that the details are even better than conventional microscopy. The camera is just picking up very high details and blowing them up so you can see them as well, which is essential in microsurgery. So by switching to this digital display technology, what are some of the advantages we can expect? Well, certainly we talked about the synchronized tracking overlays. This can provide feedback to improving your surgical technique. There are also adjustable color profiles such as preset vision blue dye enhancements, and this can improve safety during complex cases with poor visualization. There are adjustable light temperatures to help highlight anatomy, such as angle-based surgery. This provides confidence when performing new techniques. And lower light is needed to perform the same case compared to conventional microscopy. This can be safer for patients' eyes, especially when the cases go long. Then we've got multiple observers, can see the same surgeon view at the same time, which includes even using teaching pointers during the case. So this is great for having partnership between reps, industry, and surgeons to develop new technology. There's even an opportunity to broadcast digital video, which can enhance 3D surgical education at scale. And that's something that you can't just do by watching pre-recorded 2D videos. So I really think training the entire room brings the whole team closer together to provide a smoother patient experience. And here are some of those screenshots of those color and temperature changes. Imagine that you have a complex pseudoexfoliation glaucoma cataract or small pupil, and you have better highlights like high def, HDR. You can also get a sense of the overlay examples on the right. So doing your phaco machine settings, intraoperative aberrometry for premium lens, and then real-time toric alignment. This helps with crowding all the machines to be in your surgeon view and craning your neck all the time as you're looking around at different machines because everything's there. There are some papers that have been published on the Ingenuity system that speaks to some of this need for less dye intraoperatively during retinal surgery, or fewer changes in focus in anterior segment surgery, or having less light intensity needed to help the patients. And some of these maybe seem like small changes, but they pretty much are becoming normalized now as new technology is being adopted. And as surgical video becomes digitized and the internet connection speeds hit 5G as normal, then there's actually increased opportunity to spread surgical knowledge outside the OR in real time. And this is an example software by Proximy, which enables telepresence. Their company out of the UK. They help broadcast so that many surgeons can log on to a case at the same time and see the real-time teaching. It's not yet been used much in ophthalmology, but there's no reason that glaucoma surgery and cataracts can't also introduce this. So here's a screenshot of actual video from Ingenuity system. This is what the 3D high resolution looks like. It's already split into two views. Of course, no 3D glasses right now to see that in 3D, but you'll actually see what the increased depth of focus looks like. You can see that instrument is in focus all the way, the forceps at the tip, including the handle. With normal microscopy, not everything would be in focus at the same time unless you zoomed all the way out. And so it's all that refocusing and zooming in order to capture certain aspects of the surgery on video. One and done is a 3D camera advantage. Also want to show you a video. Here is an angle-based surgery, courtesy of Dr. Smith. And what you're seeing here is an intraoperative gonioscopic view of the trabecular meshwork and where the iris is inserting. The surgeon has an MVR blade to make a slit opening into Schlemm's canal. So if you do this kind of surgery, you can appreciate the high resolution of detail using some viscoelastic to split that opening there where Schlemm's canal is, so that a hydrostent through this inserter can slip right in to the Schlemm's canal space. And this is a helpful glaucoma surgery, minimally invasive. And keeping that in focus from the instruments to the view to the lens that you have. Now it's being pushed over to the side to be fully slotted in. All of that is really enhanced when you use a 3D digital system. And I think this is an opportunity here to think about the possibilities of what if there was real-time tracking guidance in that scenario. When I say trabecular meshwork, not all surgeons can know exactly where that is at all times. Some are cataract surgeons who sometimes do glaucoma surgery, but not all the time. And so having additional tracking arrows for anatomic landmark guidance, like an AI that knows exactly where you are and where you're supposed to go, can be a safety for training new surgeons and for difficult cases. So now let's look at a video of the Ingenuity system and some of the digitally enhanced surgery updates that are coming to the software. Some of these I talked about briefly already. Here you can actually see what it would look like on the large 55-inch screen where you'd select a patient, and you need to have the video tracking to match the real-time patient who's laying down. So you take the slit lamp photo from the clinic, and then you can start active tracking, just like the iris can be actively tracked with your femto cases and other scenarios. And then by fusing the machines, data fusion refers to connecting with the phaco machine or constellation so that overlays can be done on top of the screen. Here's the examples of that color changes and color profiles. So image guidance integration has to do with that patient registration so that the overlays can move as the patient moves, because the patients have little cyclotorsions. So if you match, then all of your overlays will track in real time. This is important for doing such things like corneal incisions, limbal relaxing incisions to help with astigmatism. So it's very cool that all of this has active tracking, just like our other devices that we have on the conventional scope. So now you can see that what if you wanted to make different sized capsular rhexis, you can have it track in real time, help with the lens centration with premium lens like Vivity and Panoptics, very important. So all of the things that you normally do with the conventional microscopy can also be done easily with the digital heads-up display, and maybe even better. Here's very dense cataract. You can see what the difference is between a preset blue enhancement with contrast turned on. Watch when they turn it on. And then we can see when it's also turned off. So what is the differences between how that vision blue highlights? You see there it's the switched on, and previously it was a switched off. And I think this is very helpful for more difficult cases. See, that is now turned off. So you can see that the blue enhancement is a little bit less compared to before. Here's just another example of the same thing. Wow, look at that. Blue is very bright there. So on a white cataract, this could be helpful, especially with difficult rhexis. And then when turned off, you can see our more traditional view. Let's show an example of that for minimally invasive glaucoma surgery. So sometimes the TM is very lightly pigmented, a little bit difficult to see. So see how now that brown stripe with the high contrast on, where the device is touching to the white line in the brown spot, is much more highlighted. So finally, we can just see some more of the functionality here on the software updates where we save the information. And I think that's the end of the video. Okay, so I'd like to summarize what you've seen today and heard about in terms of 3D digitally assisted surgery. I think one of the highlights for myself is that there's freedom from oculars. We have this device and use it at our institution. Certainly the improved ergonomics is noticeable, and the collaboration opportunities for the rest of the team when they see the cases takes a bit of time to set up, but once you have it all set up and going, then I have a lot of international visitors, people viewing the different kinds of surgeries, and it's very helpful for them to all see it in 3D. This is really great as a teaching institution, better teaching tool, I would say, for my fellows. And then also sharing that videos for other talks. I think it's an amazing tool, and you'll only see improvements over time. Thank you very much for your attention.